Hi everyone. This is my presentation on a 14-year-old boy with a headache, stiff neck, and erythema migrans rash. My name is Joe, and I hope you enjoy it. So, an erythema migrans rash is usually a circular bullseye rash. It can vary greatly in shape and size. It's rarely perfectly round, but it does occur in 75% of patients who present with Lyme disease. In children, they're mostly found in the head and neck and arms and legs, back, abdomen, axilla, groin, and chest. So in this boy, we'll call him Michael, he presents with a headache, stiff neck, an erythema migrans rash to his right armpit area that he is saying is not itchy, fever, general malaise, fatigue, myalgias, and swollen lymph nodes. And he's had these symptoms for about a week, and his mom brought him into the emergency department. So when he comes in, we draw some labs. His white count is normal, but he does have elevated inflammatory markers. His ESR and CRP are elevated. His AST is slightly elevated, and his urinalysis shows microscopic hematuria and mild proteinuria. This picture on the right-hand side I thought was interesting. I found it as reasons for elevated ESR. And in his case, he is the I for infection, inflammation. So I learned a lot about serologic testing for Lyme. It's not as easy as just taking a blood sample and testing for Lyme disease, and if it's positive, treating. A lot of people, if you test them for Lyme disease, will have positive IgM and IgG antibodies if they've been exposed in the past to Lyme disease and have developed antibodies. And often also in someone who has early Lyme, it's not going to become positive. The Lyme antibody detection tests take a while to become positive. A lot of people who are in the early stages of the disease are seronegative. The Borrelia species that causes Lyme disease, they alter surface antigens during the disease in order to avoid immunologic detection. Testing him for Lyme disease when he has all these symptoms plus an erythema migrans rash wouldn't be, it wouldn't be indicated. And a lot of people as well, if you do the, enzyme immunoassays, will have false positives because they have low specificity. So, in the United States, erythema migrans is the only manifestation of Lyme disease that permits clinical diagnosis without laboratory confirmation. I would not test him for any of these things. I would just go ahead and treat him. So, Lyme disease, first thing I want to do, what I did find on the CDC website as well is that in 2015, 95% of Lyme disease cases were reported in 14 states. Connecticut, Delaware, Maine, Maryland, Massachusetts, Minnesota, New Hampshire, New Jersey, New York, Pennsylvania, Rhode Island, Vermont, Virginia, and Wisconsin. So he's definitely in an endemic area. So I've decided that he's in the early localized stage. He's having all those flu-like symptoms. He's got the erythema migrans rash. It usually occurs in the first 1 to 4 weeks after the bite. He's got lack of energy, headache, stiff neck, fatigue, chills, muscle and joint aches and pains, and swollen lymph nodes. So because he's inpatient, I think I really wanted to treat him with IV antibiotics. However, UpToDate states that it's not superior to oral agents and not recommended as the first-line agent for the treatment of Lyme disease if there's an absence of neurological involvement or third-degree AV heart block, which he doesn't have those symptoms yet. So I would treat him with Doxycycline, which is fine for him because he's 14, and we know that tetracyclines in children less than 8 years of age can cause that permanent teeth discoloration and are contraindicated. So doxycycline is a tetracycline. It's metabolized a little bit in the liver, excreted in the feces and urine, has a long half-life of 18 to 22 hours, and is bacteriostatic. So it works by inhibiting protein synthesis of the bacteria. And while you're on it, you're going to want to monitor BUN, creatinine, CBC, and LFTs if you're on a prolonged course. For Michael, he is 50.9 kilograms, and so Up to Date recommends 2 milligrams per kilogram per day, PO divided into two doses for 14 days. So for him, that's going to be 50 milligrams of doxycycline oral twice a day. We are going to obviously look out for a hypersensitivity reaction and some of the adverse reactions, such as severe photosensitivity, C. diff-associated diarrhea, severe skin reactions. Watch those LFTs and look for hepatitis, and also hepatotoxicity. So it's important that we trend those. Some common reactions that we'd want to educate him and his parents on are headache, nausea, arthralgia, which he already has, diarrhea, photosensitivity, mild photosensitivity, and candidiasis. Also BUN elevation. So I think while he's in the hospital, I'll just do daily CBC and LFTs and BMPs. So possible interactions, if he was a 14-year-old girl, I would ask about contraceptives and make sure that if she was taking a hormonal contraceptive, to educate her to use a backup method. He is not taking these because he's a he, so we don't have to worry about that. Ask his parents and him about whether he takes any herbal supplements like black cohosh or St. John's wort, because there can be issues with hepatotoxicity and increased photosensitivity with those. I'd want to check his history and make sure that he does not have a seizure disorder and doesn't take carbamazepine, because this can decrease doxycycline levels. He does not have a seizure disorder, so we don't have to worry about that with him. And then bactericidal antibiotics in general can decrease the efficacy of bacteriostatic drugs or antibiotics. So if he was taking an antibiotic for any other reason, I would probably have to warn that the bacteriostatic effects of doxycycline will decrease the bactericidal action of that other antibiotic. But Michael is not taking antibiotics for any other reason. So while he's in the hospital, I could use acetaminophen sparingly. I'd want to definitely watch those LFTs, but if I was going to give him maybe a one-time dose, if he was really uncomfortable or if he had a very high fever, headache, I could give him 325 to 650 milligrams PO every 4 to 6 hours as needed. But again, be really careful with that and watch his LFTs. I could give him ibuprofen for its anti-inflammatory effects to help with his aches and pains. He could have 200 to 400 milligrams orally every 4 to 6 hours as needed. For his stiff neck and in general his muscle aches, I could give him a heating pad and help relax those muscles. If he's having some of the nausea, vomiting, GI upset that doxycycline can cause as a side effect, I could give him Zofran, 4 milligram dose IV or an 8 milligram dose orally. And I'd want to watch him again closely for diarrhea. If he's having 5 loose stools a day, I would test him for C. diff. He's also going to need lots of love and support, rest, sleep, exercise, and physical therapy, especially as his aches and his joints start to get better. We're going to want to get him more mobile. While he's in the hospital, I'm going to monitor him on telemetry. It's really important that I do this because the later stages of Lyme disease can cause cardiac manifestations such as AV node blocks, myocarditis, and pericarditis. So watching that telemetry for blocks and then also any symptoms of chest pain or chest tightness or just any cardiac symptoms, I would want to watch him for that. I'd want to do frequent neuro checks and assessments to make sure that the neuro manifestations of late Lyme aren't coming, such as the Bell's palsy or facial palsy or other cranial neuropathies. Lyme disease can cause Lyme meningitis. It can cause some motor and sensory neuropathies. And then late stages can cause encephalitis and encephalopathy with cognitive difficulties. So just watching him very closely, monitoring neurosymptoms, and all those things are important. There's also rheumatologic manifestations of Lyme, such as effusions in joints, and I'd want to watch him for those as well. So if he doesn't respond to oral doxy and he starts to get some of these central nervous system symptoms and his disease is progressing, then I'll switch him to IV antibiotics and do this ceftriaxone 2 grams IV daily. If we started IV antibiotics and in a couple days his symptoms started to dissipate and he started to feel better, he could theoretically go home. We could have a case manager set up home health and a nurse could come and administer the antibiotics via a central line or a PIC, so he wouldn't have to stay in the hospital for the entire course. And then just teaching, I'd want to educate both him and his parents that if I am sending him home on oral doxycycline, let's say he was in the hospital for 2 or 3 days, started to feel much better, his symptoms started to dissipate, and I was going to send him home to finish the 14-day course, I would want to make sure that they know that they have to finish the entire course. Even if he starts feeling better and the rash is gone, that every pill has to be finished. I would educate while on doxy to use sunscreen, wear hats and long sleeve shirts because doxycycline increases sun sensitivity and can cause severe sunburns. And again, to watch out for that diarrhea, and if it persists, to call his PCP office for a C. diff test. Lastly, I'd want to give preventative teaching, so to educate them on preventing further tick bites. So if you are outside in the woods in high grassy areas, to do regular tick checks of your skin afterwards, to try to wear long sleeve shirts, long pants, and hats while you're outside. And, to try to avoid low-level shrub and grass areas, especially on the edges of wooded areas where they tend to like to be. And then educate them on what they should do if they do find a tick again on their child. So to remove the tick and watch for symptoms, and keep the tick in a jar. Note the size and color, and if the child starts having symptoms, to call the pediatrician, because in some cases the PCP or provider may prescribe antibiotics to prevent Lyme disease, so like a one-time prophylactic dose of doxycycline. Here are my references. I used a lot of references from the Centers for Disease Control and Prevention. I used my Sanford guide as well as Up to Date, and I also used Hippocrates, and then some websites such as Boston Children's Hospital and University of Michigan Medicine. I hope you enjoyed my presentation and that you learned something.